Thank you to Klaus again for inviting me to Presbymania. I'm going to talk to you a little bit about an update of corneal inlays. So there's a bit of a history there. Joseph Barriquet put corneal stromal lenticules into eyes. They work well in terms of biocompatibility, but subsequent investigators and researchers and surgeons have put in synthetic implants, and unfortunately they've tended to have issues. And the last era, up to about 2002, Permavision put in a synthetic inlay, which unfortunately it was made for hyperopia correction, and it tended to extrude, and the product was withdrawn. But there's been a resurgence of interest in these presbyopic inlays, and there were 4 of them have been available commercially up to the recent past, and that was camera, Presbya, Eco-Lens, and Raindrop. All of these are synthetic material inlays. All of them need femtosecond laser pockets or flaps, and at various depths, and all of them are put on the visual axis of the non-dominant eye. All of them are removable, and all of them require the same screening process that you have for most of your presbyopic patients to work out whether the patient's suitable. The camera inlay is a donut-shaped inlay with randomly scattered little holes in the opaque donut. It's 3.8 millimeters in diameter with a central hole of 1.6 millimeters. It's more than 10,000 have been implanted. It improves the depth of focus. It's implanted under 200 micron flaps. There's only one model, and it's available. You can do it with LASIK. FlexiView is a different product. This is a little 3 millimeter implant, which is refractive. It has a different refractive index to the cornea, and it has a central zone which is plano, and a peripheral zone which produces the ad. And fewer have been implanted, only 1,000. It's implanted really deep in the cornea, 300 microns, and you can do concurrent LASIK with it. And there are different implants available with different ads. The Raindrop, about 2,000 were implanted. It's a non-refractive implant, and it's only 2 millimeters in diameter and has no refractive power, but it changes the shape of the cornea. The Raindrop you can do concurrent LASIK with it. That's a picture of a Raindrop under a flap, and when it's in the eye, it's almost impossible to see. There's only one implant model. You don't change it according to the patient's degree of presbyopia. And in terms of efficacy, they are all effective. Looking at the preoperative and the postoperative implantation data, they all improve the near vision in the eye that's been operated on. However, there are problems and issues with these inlays. The one problem is that there are very few peer-reviewed publications, and the peer-reviewed publications that are available are of limited duration and of limited numbers. Camera has the most. It's been around for about 10 years, and there's one study which is quite big. It's 507 eyes up to 36 months follow-up, but otherwise a lot of the studies are really, really short, and that applies to all the other peer-reviewed publications. Problems with the outcomes reporting are essentially that they don't, and this is for all our presbyopic treatments, is that illumination is not standardized. We all know that you can put a football stadium type spotlights on the page behind the patient, and you will gain wonderful acuity, and you just vary the illumination according to your testing. And that's a big problem with all of our outcomes testings with presbyopic treatment reporting. The other issues are the test types and techniques. Of course, there are differences between the JAGA. Even within JAGA, there are different JAGA standards that are used, because it's an old print type standard, and there's no standardization even within JAGA. Most studies don't report distance-corrected near visual acuity, so they just report near visual acuity, uncorrected near visual acuity. Intermediate vision is only reported by 50% of studies, and the common amplitude is not necessarily assessed, and there's debate amongst which is best, whether it's subjective or objective is optimal, and there's even some debate about whether we should use task-orientated reporting, such as reading a newspaper or reading a computer. The problem with this is that the studies all vary in terms of their outcomes reporting, so the comparison of the studies and comparison of the inlays is very, very limited. But the big problem with these synthetic inlays is the biocompatibility, and confocal microscopy reports have shown that they all produce some sort of inflammation with apoptotic stromal death, which happens even with LASIK, and this inflammation has been present up to 6 months postoperatively when it's been evaluated in a time scale. And this is present for all the different inlays. They all produce a slightly reduced monocular uncorrected distance visual acuity because they tend to be geared around trying to create a sort of mini monovision or monocular distance and monocular near type outcome. But they are usually safe and removable with good reasonably good best corrected acuities after removal. But 1 to 2 lines of loss of best corrected visual acuity is very common with all of these inlays. So in terms of safety reports in the literature, they do loss of 2 lines of best corrected visual acuity is apparently only occurs with the camera, but that's in the literature reports. In anecdotal and non-literature report studies and in presentations like this, you'll often hear about losses of best corrected acuity. Glare and halos does occur with them. They often need to be recentered if they're decentered. All of them have suffered from the problem of having to be explanted, which is not unique with a lot of our compromises we do with presbyopic surgery, including multifocal lenses. All of them produce haze, which is another way of saying they produce inflammation, and all of them produce reduced contrast sensitivity. In terms of the haze, though, again, this issue arises where if you were dealing with one of these companies, they'll say, when you look at the patient, you see haze. They look at the patient with you and they say, that's not haze. We don't grade that as haze. It has to be a bit worse. So there's a lot of debate amongst the clinicians and the companies as to what constitutes haze. In terms of my experience and the literature reports, the reasons for removal are either poor patient selection, they should never have had it, they don't tolerate monovision, or else the inlay has not been centrated well, it's migrated, it's shifted in position, or even been extruded. There's night vision glare has been a reason, corneal haze, and also often the patient's expectations haven't been achieved, especially in terms of their reading vision. So I would reiterate again that these do work, but there are these issues that occur, and they tend to occur progressively more with time. My personal experience is with the raindrop, and I have also followed up patients with other inlays, and in my experience, patients develop significant haze requiring treatment in 30 of the 60 eyes that I treated. That's 50% of the patients. They required removal of 13, that's 22%, and this is an ongoing issue. I'm still seeing patients that are coming back to me and require removal. I've had 3 patients with corneal melts where it's extruded through the front of the cornea, and 1 patient with infection. I don't think that's the fault of the implant. Looking at the haze occurs between 1 and 9 months post-operatively, so it can happen quite late. Now, each haze episode is treated with 3 months of steroids. So if a patient has 3 episodes of 3 months treatment, that's 9 months they're on steroids. That's a lot of chair time for me. And often the haze doesn't resolve, especially the longer it's been there and the longer after the implant it develops. And the haze is often associated with 1 to 2 lines of loss of breast corrected visual acuity. And now I'll tell you about one of my patients, Mr. GP. He's about born 1962, he's 55 years old now. He's a planar emmetrope with right eye dominant. Uncorrected distance visual acuity is 6.5 in each eye. I put the raindrop inlay into his eye in May 2014. At 1 week afterwards, he was happy. He had uncorrected distance visual acuity of 6/7.5. It was minus 0.50 because the inlay does cause a bit of mini monovision. 6.6 distance vision, but J1 at 20 centimeters, J2 at 40 centimeters, and he had his topical steroid for 3 months as prescribed. At 4 months, he developed haze. So I put him on steroids for another 3 months. He'd only been off for a month. At 8 months, he still had hazy vision, and his reading was wearing his reading glasses again. By this stage, his uncorrected near visual acuity in this treated eye, and that's a picture of his eye, had dropped off to 6/24, and I put him back onto another 3 months of steroids. He's had 15 follow-up visits over a period of 3 years, and he's still in his reading glasses. So, at 3 years post-operatively, he said, look, this thing's not working for me, it's hazy, I want the inlay removed. So I removed the inlay. It was really difficult to remove, because it's difficult to find at the right depth, and I put him on another 3 months of steroids. He's had 19 follow-up visits to date. It's 9 months now since I removed the inlay, and this is a refraction. He's low hyperope with plus 150 with a minus 1 SIL, and his best corrected acuity is 6/7.5 and uncorrected, and that eye 6/12. So he says to me, he's a nice guy, he's very understanding, but he's got reduced acuity. He regrets having it done. And this is a patient I saw just about a month ago. He had, I treated him in September 2014, again a planar emmetrope, And at 1 week post-operatively, again, very happy. 3 years later, he comes back to me. So he's got hazy vision in his left eye. He'd been wearing his reading glasses since 6 months after the surgery, but he had painful hazy vision in his right eye. And he had a painful red right eye for the last 5 days. His uncorrected visual acuity in that eye was 6/24, and best corrected acuity was 6/24 for near as well. Looking at the eye, that's what I saw. Now, if you look carefully, what you'll see is that there's a little ring that's now around the inlay, but in the center of that ring, there's also something else going on. If you look, that's I've delineated it there with a little line, and in fact, that was an erosion. That was all bare. That was inlay exposed. So I took a little Wevill sponge and I removed it, and 1 month after removal, I saw him last week. He's got low hyperopia in that eye. It's about +1. An uncorrected visual acuity of 6/12 in that eye, and best corrected of 6/9. He's doing remarkably well, but he's a very tolerant and patient patient as well. In terms of raindrop removals, this is so looking at my first 11 removals. The average removal is 25 months, which is quite a long time after the surgery. And as you can see, most of the inlays have been removed after 36 months after being implanted, and I'm still removing them. The outcome of the removals are the best acuities. They all seem to gain. They all seem to lose a bit of vision. Some of them have not lost much. In other words, they lost a bit with the inlay. With the removal, they didn't lose any more. But some lose more, and 3 of them have lost more than 4 lines of best corrected visual acuity. The best acuities were retained with those that I removed early. Those that I'm removing now are lingering with persistent haze and persistent slightly reduced acuity, and it's settling very slowly.
How many did you put in and how many did you remove?
Well, fortunately, I didn't put a lot in. I put in about 25, but the colleagues I worked with, we put in about 70.
Wow.
So, yeah. So,
and
they've all retired, and I'm picking up all the pieces. So I'm seeing these patients. That's the problem.
The ones you removed are the ones you put in.
No, two of them I removed. A lot of them I removed are the ones I put in, but I tend to remove them early. The problem ones are the ones who don't come back. They just put up with it for a long time, eventually pitch up and say, now I'm tired of it, and it's 4 years later, and I didn't necessarily put them in, and I've got to take out. They're difficult to take out, and the results aren't so great. They take longer to settle.
The one that was exposed, at what depth was it put in?
Well, I've put in, it was 150 microns. I've removed 2 that 2 have been exposed that I put in. No, so only one that I put in has been exposed, but 2 others have been exposed, I've removed.
They don't close raindrop? Just they don't close the factory?
Yeah,
yes. Well, we're coming to that. So
sorry, the story is not finished. Okay, let's go.
Okay.
Sorry.
So in terms of complication limitations, severe haze is one of them. Overlying melts and raindrop happens with the flexi view and the raindrop and the camera, and they all cause the flexi view and the raindrop cause a little myopic shift. The camera, when it gets inflamed in a sort of more ring-shaped inflammation, and it causes a hyperopic shift. So this is terrible for a presbyope to go a little bit hyperopic, which happens with the camera. The problem with the camera is you can't see the inflammation of the camera because it's opaque. And the only way to treat them is you have to use long-term steroids. So you have to put them on steroids for between 3 and 6 months. Camera are now recommending that you have them on 6 months of steroids after you put it in. It's a long time, and compliance is a problem. As you can hear, but put anything in for 3 or 4 times a day, it doesn't happen. So the risks with the surgery are essentially you have your routine LASIK risks, which are refractive surprises, flap complications, epi ingrowth, DLK, all of those types of things. But these you also get decentration, migration, reduced acuity, and they are removable, but you get reduced vision. Camera complications in addition are you get the hyperopic shift I spoke about. You get a vignetting effect, which is this sort of darkening around the images. You get glare and halos. And interestingly, there's a report in Brazil, that's actually a camera inlay, which has gone, you can hardly see it, but it's got depigmented. So the little cells, inflammatory cells within the cornea, have actually leached away the pigment, and that patient's getting no benefit, but it still has a camera inlay in his eye, in her eye, actually. So it's, this is a patient I saw who came to she had a camera inlay. I'm sorry, the OCT image is not really clear, But if you, 2014, to the high myope with 607 vision in both eyes, she had simultaneous LASIK and camera at a 200 micron pocket, 200 microns, that's how deep it was down. She came in April 2017, 3 years later, with an uncomfortable eye and exposed and extruding camera inlay. It had eroded through 200 microns of cornea. So top left, actually, I put a little ring around where the exposure was, which you couldn't really see, so I've colored it in down there, but that's literally what I was seeing. And there's the OCT. You can see the overlying cornea there, but it's completely eroded away here. There's shadowing by the camera there, so that's why you don't see, that's why the OCT is shadowed there, but there you can see the exposure. She had 6 months post-op now. I removed that again with the wet cell sponge with the slit lamp, and I also covered with antibiotics and things like that. But she's 6 months post-op. She has 615 uncorrected vision in that eye, but she's myopic. And she's J3 uncorrected, and she happens to be happy. So I'm very thankful for that. But the other camera concerns are what you do about biometry for cataract surgery, what you do about flax, femtosecond laser surgery with these patients, what about YAG capsulotomies, IOP monitoring, gonioscopy, visual field testing, peripheral retinal examination and VR surgery, and lamellar corneal surgery with PKPs if the patient needs that when they're older. These are all unresolved issues. In terms of, we talked about the safety, I won't go into that too much. So it sounds as though we're sounding very much like the old PermaVision story back from 2002, so I don't think we've come a long way in 16 years. As you know now, also Raindrop, you've heard, my thunder's been stolen, but Raindrop closed its doors. So you have it now, it's the 28th, so you have until another 2 days to call the hotline number. The company have left me, abandoned me, and I will have to sort out all these problems on my own. I have 2 more days to call a hotline. I'm not sure if the hotline will give me a lot of help. Anyway, so we asked about what about the other ones? Well, Presbya, this is 2017, required additional financing for their operation. And we'll see them through to the end of 2018. I'm very reassured. Am I going to embrace Presbya? That's a big question. And this is their financials. They are losing money from the Wall Street Journal. They are losing money and they're continuing to lose money. So AcuFocus, they produced the camera inlay. They raised 66 million. They've been around for 10 years. They're the market leader in this field and they're still needing to raise money, this was back in 2016, to keep themselves afloat. So, however, there are new arrivals into the market. This has not daunted anybody. So we have a group from Valencia who's now created a camera type of lens, but with little holes which create a diffractive focus, and they believe that this will create a better near vision results. However, this is still a synthetic product. So they are launching this product.
You would try it?
Of course.
It's not going to work.
I love this guy because 5 years before we say Raindrop is really good. He's good.
When I believe the company, I was naive, I was young then. However, there's still a hope at the end of the horizon. Allergenic corneal inlays. Remember Joseph Barriquet in 1949, he was probably quite right. He used frozen corneal lenticules to implant in the stroma, and he was probably right. And now, Michael Mroshin and Dave Muller are using donor lenticules and freezing them and putting them into creating little blanks which you can implant under the cornea and in the central cornea, and again put in these which should be more biocompatible because they are after all donor cornea. But you ask, well, what about all these lenticles that are removing the smile? Well, Susan Jacob in Chennai in India has developed this technique called PEARL, which is Presbyopic allergenic refractive lenticle corneal inlays, and she is taking these little smile lenticules which remove, cutting up into little pieces, and going to start freeze drying them and making them available for sale. Who owns the property of my lenticle which I have removed? That's another debate, but anyway, she has treated 15 patients up to 2016 and is producing quite good results. Of course, we always have to stack up these technologies with the alternatives, which is glass and contact lenses, monovision LASIK and LASIK, multifocal IOLs, these new ones like the power vision lens. What about the eye drops, femtosecond lentotomy, and new lenses? These we have to stack up with risks and benefits. So in conclusion, they are currently available commercial products, but in long-term inflammatory responses with long-term haze issues and corneal melts, it takes a lot of chair time before you put them and even more chair time after you've put them in. And I think the future is probably with allergenic inlays if you're going to go that way with inlays or long-term better IOLs. Thank you once again.